Hi, it's Jonathan,
And I'm Emma.
and welcome to
Cut
Cut
to
to
the
the
Case.
Case. And Emma, I've got a case. It was quite a scary case, actually, this one. So I need to share it with you because I was a bit frightened by it.
Full disclaimer, I don't know anything about the case, so I'm listening to this just as you are. Off you go.
So we get a call about it's a 25-year-old guy who's got some sort of post-tonsillectomy bleeding. So he's had a ENT procedure. He's 8 days post either tonsillectomy or adenoidectomy and maybe a septoplasty. So he's had an ENT procedure and he's got an epistaxis, and he's got an uncontrolled epistaxis. He's coming in 5 minutes. And I get that
Vital
call.
signs or
Vital signs: heart rate 130, blood pressure 140, and he's talking and he's conscious. But that's the situation.
I guess the 130 that would provoke a whole lot of anxiety. So it could be that, or it could be his hemorrhagic shock. I guess is that kind of what you thought?
That's my thought. But
and what did you prepare?
What do you reckon my anxiety was like?
I think it will be high. Why is it high, Jonathan? Two parts of the ABC are affected. In fact, A and B and C can all be affected.
Exactly. So why does this make me so worried? Because often you can't stop the bleeding.
Yeah.
And the airway,
and it's in the A, and that can drop down into the B.
Will be difficult, and I won't be able to intubate him. So that's what I was worried about.
Okay.
It's going to be something I couldn't control.
Yeah.
So we got set up,
and it's not easy to compress that site, right?
Well, that's the problem, right? So things that I can't easily control myself would make me worried. So I said that. So I'm worried this might be a problem I can't fix.
Does your mind jump forward to the absolute worst case scenario?
Worst case scenario.
And so what's that look like?
Well, he's unintubatable, and he's bleeding to death. That's what I'm thinking.
And so what are you thinking to do about that?
So I'm thinking I might need help from anesthetics, and I'm thinking I might need help from ENT.
Okay.
So
and you want to press the bleeding site. If it's tonsils, you know how you think about the big forceps and the gauze and the adrenaline and shoving it in the throat and holding their head. That's what I think about.
Gill's forceps. That's what I was thinking. But look, so all those things that are going through my mind as I'm setting up, what would you set up?
So you'd need a group of people. So you'd need good nursing staff, and you need your doctor. You'd probably get some airway equipment ready. Worst case scenario being to intubate them. You'd really want suction, I think. You'd think about IV access, and you'd think about drugs you might give, so pain relief, but also TXA. And you might do some TXA gargle. Now, it could be bleeding from the nose or the mouth. It could be epistaxis, posterior epistaxis, or it could be tonsil, I guess.
Exactly. And I was thinking of those things, which mean I got a ENT epistaxis kit. So we've got a purpose-built epistaxis kit, which I would recommend you get ready, because the thing with this is it's getting all the equipment to the bedside. So getting those, double balloon things to the bedside, getting the ENT torch, the light, all together in one kit, which is what we had in a little box. So I had all that ready to go. And in that kit, I've got, syringes to inflate the balloons and things that you just need straight away.
And you light source on your head.
Yeah, and so I didn't actually get a light source with that, but I just use a normal otoscope. Patient wheels in, and he's sitting up, and blood. He's holding his nose. Actually, he looks all right. So he's sitting up. He's conscious. His heart rate's high. There's he's holding his nose. There's a bit of blood in his mouth. What's your first step?
So where's he? Is he bleeding?
He's bleeding. Yeah.
Okay.
Bleeding out the nose and out of the mouth.
So bang, bang.
Bang, bang.
Both nostrils?
It's a bang, bang, both nostrils.
Okay.
And both nostrils are actually packed with blood. So they're actually packed with clotted blood.
Okay.
So I'll tell you what I did, because you're obviously, where do we start? So I just started as I normally do. So he's okay. He's able to talk, but not so well. He's got blood in his mouth. And I said, just spit some of that stuff out. See if he can spit it out. He's having trouble spitting it out. But he was breathing okay, and so
not aspirating the blood. So he's conscious, he can control his secretions, he can spit it out.
So I thought, let's address the nose, because that's where the blood seems to be coming from. So I get my little nasal sucker, and I start sucking the clot out, because in my book you need to remove the clot before you can do anything else.
So he's sucking there, but it's unlikely to be coming from the front.
I'm sucking the nose to get the blood out, because I think it's adenoid. It's adenoids and it's septum, and maybe tonsil. We're not actually sure. It's definitely 8 days post-op, we now know.
Scab's fallen off, something's bleeding.
Fallen off, and this is the classic time post-operatively. So I started with the nose, and I sucked out the clot, and the clot was coming out great. So the clot's coming out, and then I use cofenolcane spray, which is what we have, which is a topicalizer, so it's an anesthetic and it's a vasoconstrictor. So I'm sucking clot out, I'm vasoconstricting, sucking, vasoconstricting. I get both nostrils clean. Still bleeding.
Out the back or out the front? Or everywhere?
Out front, still coming down the back.
Okay.
What do you do now?
Well, a lot of things jump to mind. So you want to stop this bleeding because that will protect your airway and stop breathing being a problem. And he doesn't need oxygenation at the moment.
Well, I can't put oxygen on because I've got all this stuff
pouring out on
his nose. Yeah.
Okay.
Yeah.
And can you stop the anterior component?
It's just leaking a little bit. Yeah. So it's too much for a peg.
Okay.
Too much for a peg. What
can you think about packing the nose?
Yeah. So yeah. Is it time to put the nasal tampons in, or should I have a look at the mouth? Because he's actually got a lot of stuff in the mouth. I like to look in the nose.
Tonsils out?
I'm not sure. This is the thing.
Okay.
It might be adenoids. It might be tonsils. He's
not a note
really able to know it's another hospital. So and often these things are done in
privately.
Private hospitals. It's a standard procedure, and they come to emergency for us to help. So that's why we need a standard kind of approach to this problem. Look, I have a look in his mouth, and his mouth's totally full of clot. Like it's actually full of clot. And all the while I'm sucking out the nose, it's actually filling up in his mouth. And then he starts to do this thing, and he's actually now aspirating, and he's now actually choking and losing his airway.
So I guess it doesn't matter where he's bleeding from, but you need to stop that. So you need to remove whatever's obstructing his airway.
So thankfully I had a really useful helper, other doctor who was phoning ENT.
A whisperer of wisdom.
A whisperer of wisdom. And he also suggests, how about you get a bigger sucker? How about you get a Yanker sucker, or you get a decanto sucker, which is a wide bore sucker. Decanto. And I said, you know what? There's no time for that. So I went back to first principles. I stuck my finger in his mouth and I did a finger sweep, as you would do for first aid. And you wouldn't believe it. There's a clot about this big. Seriously, I delivered a clot.
Yeah.
He was actually choking on the clot. So by dealing with his nose, the clot had been falling down the back. So I managed to extract all the clot. I managed to then get the decanto, pop it down his throat, suck out the area, and then I could finally see what was going on.
And how did he cope with all that?
Look, he was amazing. He was really relieved that I could remove the stuff from his throat, and now he was able to talk. It's not my tonsils; it's my adenoids. So
he didn't have a tonsillectomy.
No,
he had an adenoidectomy. Okay, so going backwards, he couldn't tell you because he was busy choking on clot.
He was busy choking. So
there's not really a posterior epistaxis.
Really posterior epistaxis. So,
adenoid bleed.
Yeah. So if we
forgive us ENT people if we've got that wrong.
So and that's what it was. But this is the situation, right? So we weren't sure. Let's deal with tonsils. If it was a post tonsillectomy bleed, Emma, what do you do?
Well, everything you've just done. If there's a threatened airway, but if there's a non-threatened airway and there's bleeding, then you're doing some simple things like IV access, analgesia, give some TXA, probably gargle some TXA.
And the TXA. So advice over the phone from ENT was, well, has he had some IV TXA? And so we'd done that. I was thinking of nebulizing, but I think for tonsils, probably a gargle. So gargle and an IVT.
Tip the vial into a cup, dilute it so it's a gargleable volume. That's it. Gargle it.
And so the idea is to coat that tonsil bed because the scab's fallen off the tonsils. We're talking tonsillar bleeding. Now, the next step you could do for a tonsil bleed.
Well, if it's are we jumping forward to catastrophic hemorrhage with the McGill forceps and the McGill pressure? Which you would do if as a going to theatre step.
Yeah. So
and it's not a choice; it's a patient that's bleeding, right?
So this is we're going to theatre. This is a bit like what we've spoken about with compressible hemorrhage and other sites. So we're going to theatre. I'm going to actually put pressure on until such time as we can go to theatre.
Now, going backwards a step, that middle person that has been bleeding, they gargled the TXA, it settles down. You can see clot adhered to the tonsil, but it's sort of vaguely controlled. What do you do there?
So from there, they're probably actually going to be all right. ENT will come in, they'll have a look, and then they'll decide whether they need to go back to theatre or not. But from an ED perspective, we've got control, and that's probably all you need to do.
Yeah, I think you need an endpoint, and your endpoint is control. Yeah. And I think you've said it perfectly. You've already got to that point, so sit tight.
Perfect, of course.
Yeah.
So that's tonsils. But getting back to this case, this is adenoids, and adenoids, you know, I had to revise anatomy, to be honest, but it's kind of the back of the nose.
So can you control it with your standard posterior epistaxis management?
Epistaxis, yeah.
So what did you do? Stick in a Foley catheter or stick in a nasal catheter?
So you can use a Foley catheter, or you can use a we've got Rapid Rhinos. That's a brand name, but it's a double balloon catheter. So you pop that in all the way to the back until the patient's kind of gagging backwards. Inflate the posterior balloon, just pull it to anchor, and then inflate the anterior balloon. You could argue
bilaterally.
You could argue you don't need to do the anterior balloon, but hell, I was doing every balloon, and then bilaterally. But he had that septoplasty, so it was really sore. But I did both. Yeah. So and morphine is the other thing. So I use a bit of morphine to relieve the pain, to increase the comfort. So a posterior epistaxis in a non-traumatic person, a double balloon.
Okay.
If it doesn't work on the one side,
so you pulled the clot out, it's still bleeding.
Spray.
Both double balloon catheters into both nostrils. Inflated the back one, pulled, inflated the front. What did it look like then?
And then it stopped.
Well done.
And so just a little trickle, a little trickle down the back. And he'd had the TXA. Remember, he had the TXA, and then a little trickle. ENT comes in and say, you know what, it's all good.
Okay,
this is okay.
So how do you
settle?
What's your training and your skills that you need to acquire to be able to do that?
There's a couple of things. So there's the practical stuff about ENT procedures. So, and that's all. And I didn't mention PPE. That was my first step, actually. Put PPE
blood all over your face.
Put the gown. You know, people. What are you waiting for, Doc? What are you doing? I'm not going there because I need a face visor. I need PPE.
You're certain to get a spray.
Good light and a good lighting mechanism. So whether it's an otoscope or a headlamp or something like that, good suction. And
a trolley with all your equipment laid out. Yeah.
Yes. And then a second in charge person or a helper who can make the phone calls, who can make the suggestions, who can give me the words of wisdom and say, you know what?
Whisper of wisdom.
Whisper of wisdom.
And I would say that your nursing staff are hugely important here. Anticipating what equipment you like,
absolutely,
what equipment you may need, knowing where the suction is, connecting it, and working as a team. Well done.
And then, it was exciting pulling the clot out. Oh my God, I don't think I've ever done that.
Were you worried he had hemorrhagic shock, or it was really just clot?
It was more the threatened airway.
Yeah, it sounds like that.
And the fact that we weren't going to actually stop the bleeding.
Okay, so let's just say that didn't go so well in 1 minute, and that they continue to have a threatened airway or become hypoxic, and you're not stopping the bleeding. What are you going to do in terms of crash intubation?
So we need to take control of the airway.
Okay, and how do you do that?
So now it would depend on whether I had anesthetics, but my technique for this would be, I would induce him, I'd intubate him, and then I would pack everything.
And anything else different that you would do in your intubation? I'm leading you down a path.
You are leading me down a path. You're leading, so why don't you take it from there? It's a high risk airway.
It's a high risk airway.
They're a high risk
airway.
You know, we get anesthetics if you've got anesthetics. You get all your friends. You get a surgical setup. You get in case you need a surgical airway. But ultimately, it's going to be what kind of intubation technique I'm most comfortable with.
Yeah.
And if it's me, I'll do standard laryngoscopy. I'll probably just use a normal blade. A Mac 4 blade, and I probably won't actually use a video laryngoscopy because the blood will clot the camera. So I'll just use a normal one. But that's me. I mean, if are you trained in fibre optic intubation?
Well, I think with fibre optic, you're not going to be able to see anything. So the camera is going to be obscured, the light's going to be dark. So I think reverting to old-fashioned stuff like direct laryngoscopy.
Like what you're good at. So like an old person
So maybe using a bougie, aiming for the bubbles if you can't see anything, double suction, decanto suction again.
Get your nurse to do the suction as you're doing it, or your airway assistant. So whilst you're looking, have someone actually suctioning for you whilst you're looking.
And the step back is really important, is to declare it's a difficult airway so that everybody's got that shared mental model, and even go as far as to palpate from the sternal notch up, feeling your cricoid cartilage, feeling the cricothyroid membrane market, and get someone prepared, both mentally and from equipment point of view, to do it.
Just get them ready to go. So just get them ready to go and have a set oxygen saturation or a set point where they just start doing that procedure.
Yeah.
But I mean, that's what I'd do if I was in that situation. Thankfully, we didn't get there.
Great. But, good job. So we covered the pre-setup. We've covered, removing the clot and how to deal with the choking patient.
We've covered the medical management as well. Yeah. So there's medical management and surgical management.
And then finally, in the worst case scenario, needing a crash intubation, that idea of double setup and declaring to the room. Sounds good. Well done.
Old school laryngoscope.
Yeah. Next time you could brief me on the case before we do the case.
No worries. And that's the end of Cut to the Case for this week.
See ya. Ciao.